Guys, so before we answer, no case-specific questions, unfortunately, because we don't like to mislead. You know, it's a very nuanced discussion, so please don't take our words as a gospel truth. Just use this as a more educational sort of guidance. But we are very happy to see, based on where you guys are. If you're here, I can see you the next day. Okay, so I'm very accessible, and Dr. Anthony's very accessible. But you know, just take it in a spirit of more educational rather than precise medical advice.
Hey, so thank you, Dr. Thor, Dr. Del Rivera, and Dr. Chauhan for your great presentations. So I have a really big question. So now that there might be alpha trials coming out, how will you decide between retreatment and alpha for those people who progress after their initial 4 PRRT?
All right, I'll take a crack at it. That's a very good question. You probably have heard a little bit in the prior talks that there are now newer forms of PRRT. What we talked just right now, the Lutathera, it's a type of radiation which is beta emission, okay? Now there are different compounds coming which releases a little bit different type of energy or alpha radiation, and it's not that one is better than other, right? It's not like CT scan's better than PET scan. They both have their roles. So one way to kind of simplify it for you guys is that one has a little bit more penetration or depth, but is not able to, is low energy, and those are higher. So I think there is a role for both. Now, with regard to that clinical trial, the alpha particle trial, we are opening it at Markey Cancer Center, and that trial is restricted to patients who have previously been on Lutathera or PRRT, okay? And that is going to be a national study. I'm sure it'll be probably open at Mayo and many other sites, okay? And the data from Dr. Del Passan's group in Houston is looking very promising on alpha PRRT, okay? So it certainly have a role, and we believe in it. That's why we are opening it here. We like to give multiple options to patients, right? There might be a patient who has had amazing benefit from Lutathera and did great and had no side effects, and does not feel comfortable changing therapies, stuff which worked for them previously, and it's completely reasonable, and we have net retreat trial for them, right? So it is really not about us dictating what patients should get, but increasing the treatment option, and it's a better thing to do, right? And I foresee that alpha PRRT patient can still qualify after the net retreat, and I'll have to kind of look into some details into it, but these are all the tools, and really one should not exclude other. It's about what patient feels more comfortable. I'm very happy that now they have 2 trial options in that retreatment setting. Not as a hard inclusion-exclusion criteria, as long as the patient has somatostatin receptor positive tumor. Those are the locks that we talked about. As long as you have the target, be it alpha or beta, be it Lutathera or alpha PRRT, they're both targeting somatostatin receptor. So the tumor size won't matter, at least in the trial. However, post-trial, we will do ad hoc analysis. We will study which are the patients who benefit best with alpha or the beta, or the big tumors benefit more from alpha, and the small tumors benefit more from beta. Those are all research questions that we will try to answer next 5 years.
Okay, next question.
Yes, I had a question for Dr. Del Rivera. I understood that you said that the parathyroid could pull calcium from your blood, and so therefore, if my question is, can that cause osteopenia and worsening osteopenia over time?
Yes, that's a good question, and that's correct. As I was saying earlier, the parathyroid glands are very, very tiny glands that is localized on each side of the thyroid gland, and they produce a hormone. The hormone that the parathyroid gland produces is called parathyroid hormone. And thyroid are responsible for regulate the calcium in your body. When there is an excess of parathyroid hormone, then they take the calcium out of the bones, and that can definitely cause worsening of the bone density, osteopenia, osteoporosis. And that's the reason why whenever we have a patient that have active parathyroid hormone, because of we have a little mass on the parathyroid gland, that's an indication to do surgery. Otherwise, the bone density of the osteoporosis can get worse.
So a follow-up on that.
Yeah.
How do you test to know if you've got excess?
Yeah, there is we check the parathyroid hormone in the blood. So that's, and together with the calcium levels as well. So if we have elevated calcium levels with elevated parathyroid hormones, that's an indication of what we call hyperparathyroidism, which is often associated with NCAN. Of course.
Thank you. Next question.
Hi, I'm Jan from Chicago area. A person from our support group wants to know if they have a non-alcoholic cirrhosis of the liver, would they be exempt from PRRT?
Dr. Alvin, do you want to take this?
Yes, so that shouldn't be a problem. So as long as the liver function is reasonably good, so you can have some abnormalities in your liver numbers and still treat with PRRT. So what we have said, as long as your bilirubin is not more than 3 times the upper limit of normal, we would actually go ahead and treat the patient. So we would have, in certain situations, we actually would want that person to meet with a liver specialist before we make a move on the PRRT, but that by itself should not be an issue. We've treated a lot of people with fatty liver with PRRT with no problems.
Next question.
I'd like to add a little comment to that. If we start excluding non-alcoholic steatohepatitis, we'll exclude half of the U.S. So all of us have some degree of fatty liver and issues. But what the nuance comes to it, what degree of fibrosis is there? Can the liver tolerate the hit from the PRRT or the collateral damage, and is it enough? So I agree, and we also send patients, if there is the high-risk patients with the borderline liver function, to a hepatologist, and they might do a sophisticated ultrasound called elastoscan to look for the degree of fibrosis and kind of give us some sort of risk stratification. Again, this is a multidisciplinary approach of treating these patients. Thank you.
Okay, next question.
Okay, I have a 3-part question. The first one is, can you have multiple types of neuroendocrine tumors at the same time? For example, gastrinoma plus glucagon-secreting tumors. And then the other question is there a specific test to determine if you have the glucagon-secreting tumors other than testing blood sugar like you would do for diabetes? And can you go from low grade to high grade at any point? Is that how this works, or I don't know about grade change?
I can answer the first 2 questions, and then maybe Dr. Hafdanarsson can answer the third question. But in terms if a patient can have multiple neuroendocrine tumors, the answer is yes, but it's usually associated with what we call cancer predisposition syndromes, as I discussed earlier, like, for example, multiple endocrine neoplasia 1. A lot of these patients, besides of having a pancreas neuroendocrine tumors, they may have a thymic neuroendocrine tumors, they may have a lung neuroendocrine tumors, they may have a small bowel neuroendocrine tumors, they may have a gastrinoma. So, and it can, I mean, that's the reason why a lot of our patients with NCAN, we do a comprehensive screening to understand what tumors they may have. And also, the other question that you have, how do you test for those tumors in terms of the functional status based on what the clinical presentation is? And for example, just discussing about the pancreas neuroendocrine tumors, most of the pancreas neuroendocrine tumors are non-functional or non-secreting, but we have those patients that have a functional neuroendocrine tumors, the ones that we see, they are very rare, some of them are very rare, but we see the gastrinomas. So the gastrinomas are those tumors that may present with increase of acid in the stomach, and because that happens, that can be associated with ulcers bleeding as well, diarrhea. That's one of the other symptoms. Patients that have insulinoma, meaning that the pancreas is producing excess of insulin, that can also be, clinically, that can be translated as having low blood glucose, and they're very symptomatic from the low blood glucose. They feel dizzy, they feel nauseated, they have these headaches, and usually those symptoms resolve by having something that is high in sugar. Symptoms that has somatostatinomas, that is super rare. I think Dr. Halfdannerson was talking about that yesterday, super rare. Those tumors may present, the clinical presentations, they may be high blood glucose, they may also have gallstones as well. Patients that have a glucagonoma, that's even more rare. Those symptoms, besides they can have high blood glucose, at the same time they have very specific rash that is present in glucagonoma. That's very rare. I mean, I don't know if you have seen any. I have only seen one. And we see a lot of these neuroendocrine tumors at the NIH. And then the VIPomas, so these are the ones that may be associated with very profound diarrhea. It doesn't mean that they can have many times during the day, but they can also be like one time or twice, but very profound diarrhea that is associated with also electrolyte imbalance as well. So it's depending on what the tumor is or the clinical presentation, sometimes guide us as well what hormones we need to check. Then we have the carcinoids as well, and the common symptoms that we discuss, and Dr. Chauhan has discussed a lot, is about the diarrhea associated. And we usually measure that based on the blood serotonin or the urine or blood by HIAA. So I think it's important to acknowledge what the symptoms are, and based on the symptoms, that can guide us what tests we need to do. But yes, I mean, I hope that answered your questions, and I will answer Dr. Anderson the last question.
Yeah, so the last question had to do with the different types of neuroendocrine tumors, like whether they can change from lower grade to a higher grade. So it's actually we don't really know what happens there. So we know that pancreatic neuroendocrine tumors can be well differentiated and sort of slow growing. They can also be super aggressive, fast growing, and occasionally you have a patient who had a slower growing tumor who now all of a sudden has a faster growing tumor that's of a different type. So whenever you see a really sort of significant change of that nature, you should always biopsy this new fast-growing tumor. Number one, to see, is it really a neuroendocrine tumor? People can have two different cancers. And if it is, and if it's a high-grade neuroendocrine carcinoma, we don't really know if that came from the original tumor and then sort of evolved into this more aggressive tumor. There are actually now data just published a few weeks ago in one of the scientific journals saying that these tumors are probably different from the start. They come from different cells. So now I think we need to start thinking, well, the patients who have a low-grade neuroendocrine tumor of the pancreas and now have a really high-grade neuroendocrine tumor of the pancreas, these might actually be two different tumors. We don't know this yet. And it just might be that the same individual is actually susceptible to have both these types of tumors. So I was discussing this at our European neuroendocrine tumor meeting a few weeks ago with a pathologist from Switzerland, and he's absolutely convinced that these are unrelated tumors.
Anybody else have a question?
Thanks. This is a bit of a pivot on whether or not they can change grades. How frequently do these tumors go from being non-functional to functional, or the other direction?
I think there's a particular interest of mine. I think I'll take that one. So so to start with, most pancreatic neuroendocrine tumors are non-functional. So only about 20 to 30% of them are functional, and until recently, we didn't really think they changed much. But now I've seen multiple cases where someone started with a non-functional tumor who all of a sudden has a functional tumor. Or the other way around, someone started with a functional tumor that no longer bothers to make hormones. And to make it even stranger, so I've now seen a few cases where someone started as an insulinoma, then went non-functional, we're talking the same patient, then went into making a different hormone, And there's a report from reports from Europe saying that you can actually have up to 3 different hormone productions at different time points. I have yet to see someone produce 2 hormones at the same time, but maybe you have.
I'd like to add something to that. When I was training, I saw a very interesting case with Dr. Woltering, who is a very experienced, one of the, I guess, godfathers of neuroendocrine tumor. He's now retired. So we had this interesting case of glucogonoma, and we were tracking the glucagon level for, a significant amount of time, and the tumor changed its behavior. The glucagon level starts coming down, and the insulin level starts coming up. So the patient eventually flipped completely from glucagonoma to insulinoma to a point where the patient had a 24-hour glucose drip. Without the glucose, the sugar would drop down so low that patient can die from it. So we documented that, and you can actually Google that publication from several years back. So yes, the tumor behavior, we've seen it firsthand, can change. It is rare though. I don't want you to feel, oh, this is going to happen to our tumors. It can happen. We always have to, rare cancer doctors, keep an open mind. There's so much that we don't know, and we have to appreciate it and learn with every single experience, but it can happen.
Anybody else have a question? No?
Can I add just a comment on the secreting hormones? And I have seen that on adrenal tumors. And as you know, I have seen a lot of patients with pheochromocytomas and paragangliomas, and I have seen patients that have a pheochromocytomas at the same time produce cortisol excess. So we have, pheochromocytoma that's producing adrenaline at the same time that produces cortisol as well. And the excess of cortisol is translated in having very specific clinical findings. Glucose go up, you increase weight, you have this purple stria, you have a little lump in the back of the neck, the blood pressure goes high. I mean, there is very specific clinical characteristics related to the excess of cortisol. Now, in terms of multiple hormones in one patient, I actually have seen it on NCAN patients too, that they have a thymic or low neuroendocrine tumors that produces excess, a hormone that stimulates the cortisol excess. At the same time, they may have a gastrinoma, or they may have also pancreas neuroendocrine tumors that it could be either an insulinoma. So I have seen all those 3 in one patient as well, but I have seen those in the setting of NCAN or cancer predisposition syndrome.
Okay, we're done. Thank you
wonderful.
again, everybody, for being here. Thank you, docs.
Hey guys. I'd like to thank my co-panelists for sticking around. Thank you so much. I know you guys have long flights back, but I hope you enjoyed a little bit of our Kentucky hospitality. And we look forward to hosting you guys again. And for the audience, big hats off and kudos to you guys for coming here, making this event such a resounding success. And I really hope that you can join us for national meeting in Atlanta. I promise you, Marion's going to make it worth it, because I told you she knows how to party. But thank you so much, and enjoy the rest of your evening.
And also for September of 2023, we also have it in DC. We have our NCAN meeting in DC. So I better see you all in DC. Okay?
Wonderful. Thank you, Dr. Del